Bismillah ar-Rahman ar-Rahim. Salam alaikum. Thank you so much for the invitation to this prestigious Congress, and I would like to thank the organizing committee for inviting me and for the kind words of Mr. Chairperson. Thank you so much. I've been given the task of talking to you about childhood hyperthyroidism. I'm the last talk in the day, so I'll try my best to keep you engaged and awake. This is my disclosure, and let's start. Do you know who that is? He's quite old, and this started in the 70s. Colombo, yes. I'm a big fan of crime and law shows, and this is why I think I joined pediatric endocrinology. I used to watch this very often. It ran from the 70s up to the early 2000s. He's a famous detective, and this is most of the work that we do in pediatric endocrinology and adult endocrinology as well. We are true detectives, and this will be the theme of my talk. Is I'll walk you through a case that I'm currently following in my pediatric endocrine clinic, and we will do some detective work in order to solve the case. So this is a patient I'm currently following. He's a 10-year-old male who has Sanjak-Sakati syndrome. Now, Sanjak-Sakati syndrome is maybe for you adult endocrinologists, you don't see much, but we see quite a lot in Kuwait and also in colleagues in Saudi Arabia and this area of the Gulf. Now, these kids follow us because they have hypoparathyroidism, and this child has hypoparathyroidism on replacement. Now, also they usually tend to have also autoimmune hypothyroidism, not hyper, and that's why we do surveillance with thyroid function tests for these kids. Now, this patient has also a younger brother with the same syndrome that I'm also following, but he has hypothyroidism. And he has an older brother who had died, unfortunately, with the same syndrome because of septicemia. And this is his thyroid function surveillance. Now, we expect to have autoimmune hypothyroidism in patient with Sanjak-Sakati syndrome, but you see here, surprisingly, he had suppressed TSH with a moderate increase in T4. And it has been repeated and confirmed that indeed he has biochemical evidence of hyperthyroidism. At that time, we did the antibodies. The were available antibodies at that time is thyroid stimulating antibody that we do in most of these cases, and TPO. TPO was negative, and he had a slight modest increase in thyroid stimulating hormone levels. Now, this child on review had no signs or no symptoms of hyperthyroidism. He's not on any medications or supplementations. And on examination, he has the typical features of Sanjak-Sakati syndrome with severe growth retardation. Now, this child is 10 years of age, but if you see him, he will be as if he is 3 or 4 years of age. Now, his pulse was on the higher side. However, on previous review of his chart, now this is his heart rate between the 130s to 140s, and he had normal blood pressure. So some information about Sanjak-Sakati syndrome. So it is hypothyroidism retardation dysmorphology syndrome. They have the classical triad of hypoparathyroidism, growth retardation and developmental delay, and dysmorphism. It is autosomal recessive, and it's secondary to a mutation in the TBCE gene that is involved in formation of the brain, and the pituitary axis, as well as other parts of physiology in the body. Now, the most common endocrinological abnormality is part of the triad, the hypoparathyroidism. The second most endocrinological manifestations these kids are at risk of is autoimmune hypothyroidism, but not hyperthyroidism, and that's why we got surprised when we got our thyroid surveillance as it came in this patient. The third thing that these kids also suffer from, they have immunological dysfunction, especially at the T cell level, and they are at risk of recurrent infections. And this is usually the cause of death in these kids. They die of septicemia, and usually they have a really limited lifespan. The older patient in my hospital that we follow with Sanjak-Sakati syndrome unfortunately died 2 months ago, and she was 16 years of age. And this is the typical features you see that these patients have. Okay, this is very typical dysmorphological features for patients with Sanjak-Sakati syndrome. Now, hyperthyroidism in kids. The differential diagnosis is quite similar to those that you see in the adult population. The most common is Graves' disease and hashimotoxicosis, but I would like to also add to the list the effect of the COVID-19 pandemic that we're seeing on the autoimmune thyroid disease in pediatrics specifically, and also in adults as well from the literature. Graves' disease is the most common. It accounts for about 96% of cases of childhood hyperthyroidism, with a global incidence rate between 1.5 to 6.5. So let's talk more in details about Graves' disease in kids. Now, usually Graves' disease can present at any age. The youngest patient I've seen with Graves' disease was 4 years of age. However, it tends to increase in frequency with age, being most common in late childhood to adolescence, and they have the typical features of hyperthyroidism. However, a review of a cohort from our colleagues in Saudi Arabia that got recently published, they reviewed patients with Graves' disease in their center in the past 10 years, and they found that neck swelling, palpitation, and tremors are the most common cause in children presenting with Graves' disease. However, ophthalmopathy and dermapathy, unlike adults, we don't see it frequently in pediatrics. We might see exophthalmos. However, ocular dysfunction is quite rare. There are some presentations that usually may be missed, which are psychological and social, related to irritability, poor concentration, emotional and mood disturbances, as well as poor school performance. And usually in these cases, they get easily overlooked because it might be attributed to the child being a teenager or going into puberty. Now, this is a study from the United States, and it had found that in their cohort of children with Graves' disease, mood and behavioral disturbances account for 21%, and it was second to cardiac manifestations. So this is something that we have as pediatric endocrinologists and pediatricians be aware of. There are a list of unusual presentations of Graves' disease, such as malabsorption, hepatitis, heart failure, or maybe in kids with diabetes, poor glycemic control. And this is a list of autoimmune disorders associated with Graves' disease, most importantly, type 1 diabetes. And as you see on the list, Sanjak-Sakati is not an association with Graves' disease. The diagnosis of Graves' disease is similar in kids that are compared to adults. It can be diagnosed by the thyroid function test and thyroid antibody, and rarely we need to do thyroid scan or ultrasound. The thyroid function test is classic. It shows a suppression of TSH with high free T4 and free T3 levels. Free T3 are sensitive, and it can be isolated alone, elevated in relapse or in diagnosis. However, there is the famous biotin interference with our immunoassays that can lead to falsely suppressed TSH and falsely elevated free T4s. Our patient was not on biotin supplementations. Now, a lot of these families, they take supplementations in order to improve cognition in patients with syndromes and developmental delay. This patient was not on biotin, so he had true biochemical hyperthyroidism. Now, thyroid antibodies, thyroid stimulating antibodies, TPO and thyroglobulin, all can be positive in a child with Graves' disease. However, the most sensitive, specific, and reproducible is the thyroid stimulating antibodies. And this is from the same review, the cohort from our colleagues in Saudi Arabia, and they looked at patients diagnosed in the past 10 years with Graves' disease. And they found, and this is the results and the profile laboratory investigations of their patients. And as you see, it was comparable to my patient that I've been seeing. The TSH was similarly suppressed. Their T4, the median was around also moderately elevated at 24. Now, they didn't report thyroid stimulating antibodies, but they have positive thyroglobulin and TPO antibodies, which our patient did not have. This is a review also from our colleagues in Saudi Arabia, where they looked at a cohort of patients with Sanjat-Sakati syndrome, 18 patients with Sanjat-Sakati syndrome, and they found that almost a third of their cohort had autoimmune hypothyroidism, and there was no link to Graves' disease or hyperthyroidism, and also from other reports in the world, there has been no link between Sanjat-Sakati and Graves' disease. And this is what you see from their profile, basically. Now, talking about thyroid-stimulating antibodies, which our patient has, however, low, moderately elevated. Now, he has the thyroid-stimulating antibody, which is proven to be very highly predictable for future relapses in patients with Graves' disease. And this is a study from Portugal, and they found that accounting for age, sex, and goiter, and the duration of symptoms, thyroid-stimulating antibodies were the only predictor of future relapse. And this is what you see on the right-hand side. The graph is the survival analysis. And as you see in the blue line is that patient with positive stimulating antibodies, they're less likely to be relapse-free as the time goes on. Now, thyroid imaging, usually we don't require it for the diagnosis of thyroid Graves' disease in kids. However, if your antibodies are negative and if you find a nodule, of course, you will be doing thyroid scan, a thyroid ultrasound, and plus or minus a scan. And thyroid ultrasonography with Doppler flow, of course, it is similar to what is found in adult hyperthyroidism. The ultrasound on the left side is you find that the thyroid is enlarged with heterogeneous appearance, and this is thyroid inferno, hypervascularized thyroid. And the thyroid scan, you might need to do it if we have symptoms of hyperthyroidism with no antibodies, and this is an increased uptake of Graves' disease, and you see here decreased uptake in thyroiditis. Now, what about Hashimoto's disease? Hashimoto's disease is the second most common of thyroiditis. Now, occasionally in the course of Hashimoto's thyroiditis, patient might be symptomatic or mildly symptomatic for the thyrotoxic phase, the thyroiditis phase. But mostly these are asymptomatic and we don't pick them up. However, they might present in mild symptoms. This occurs early in the disease, and it occurs in 5% only in patients with hyperthyroidism. However, the duration of this phase usually is limited to 1 to 6 months. There are no reports in the literature that this is more than 6 months. Usually, but not always, thyroid peroxidase or thyroglobulins are positive. However, there is no positivity for thyroid-stimulating antibodies, as this is a process of destruction rather than stimulation. Now, are there other considerations I have to look for in my patient? Aside from this is maybe Graves' disease or hashimotoxicosis? Yes, the potential mechanism of the thyroid affection during the COVID-19. There has been multiple reports in pediatrics and in adults that maybe the COVID-19 pandemic directly or indirectly had led to a different presentation in autoimmune thyroid disease in kids, hyper or hypothyroidism. You see, it can be directly or indirectly related to stimulation of the autoimmune process or direct inflammation, as the virus particle have affinity to ACE2 receptors. Also, because of the social isolation and lockdown measures that a lot of the authorities had done to control the pandemic may have led to what we call is the hygiene theory, that there has been less exposure to community infections and led to a dysregulation of the autoimmune system, leading to more presentation with autoimmune disease and processes such as autoimmune thyroid disease, both hyper and hypothyroidism. Is this something that I need to consider in my patient, that this patient is presenting with this post-COVID? For the first time, a case is being reported to have Graves' disease and Sanjat-Sakati syndrome? I don't know. Now, this is a study that we did in patients with type 1 diabetes in Kuwait. This is data extracted from the childhood onset registry that we have established in Kuwait since 2011, and we looked at the effect of the COVID-19 pandemic on the presentation and the prevalence of thyroid antibody positivities in these kids. And you see here on the left in the figure that there is a significant increase of TPO and thyroglobulin positivity in these kids after the pandemic. And on the right side, you see the table comparing those kids with history of COVID-19, i.e. either positive COVID PCR or COVID antigen testing at diagnosis. And as you see here, more kids who have positive status have more likely to have thyroid antibodies. So this is in Kuwait. There has been a change in the face of autoimmune thyroid disease in Kuwait after the pandemic. Is this what is happening to my patient? Again, we don't know. Now, this is the follow-up of the patient. Now, because of this, at the start, patient had mild tachycardia and biochemical evidence of hyperthyroidism. We wanted to see how the child would respond and treat him as Graves' disease. However, I was very hesitant and very reluctant to start Numarcazole because, as you know, one of the side effects is agranulocytosis, and these kids are at risk of recurrent infection and at risk as well of dying from septicemia. However, I counseled the family, and we wanted to see the child response to see, is it really Graves' disease or not? And this is the follow-up of the patient. On the left-hand side, you see his TSH level, and on the right side is the free T4 levels over time. We were able to achieve fast a state of euthyroid as well, and then in the second month is that severe hypothyroidism for which we weaned Numarcazole and started levothyroxine, which is quite unusual response to kids with Graves' disease. And with this, I wanted to I'm thinking about Graves' disease less and less, so I weaned the child off medication, and currently he is off medication, as you see, and I'm not sure if this is relapse or this is another cause. However, the TSH stayed suppressed of medication, and the free T4 level stayed moderately elevated. And at that time, I did some imaging studies. Again, please, can I see? Yes. Yes, if you don't mind, just 1 minute. I did some imaging studies. Now, the ultrasound was normal and the thyroid scan was normal, which was not supportive of Graves' disease. Now, this is evidence from Saudi Arabia post-treatment, and as you see here, that recovery duration in patients with Graves' disease, usually the median is 15 months, and this is comparable to the international literature. It takes around a year or a minimum of 6 months up to 18 months for a child to be managed, for hyperthyroidism be managed in Graves' disease. Our patient was euthyroid from month 1, and then after month 2, he was severely hypothyroid. Is it Graves' disease I'm dealing with? I'm not sure. Now, this is the evidence so far for this case. What are the evidence supporting Graves' disease? Now, Sakati syndrome, they are known to have autoimmune thyroid disease. However, reported in the literature, it is hypothyroidism. Is it the first case of autoimmune hyperthyroidism? We don't know. He has positive thyroid stimulating antibodies, and maybe the COVID-19 period had led to the change of them presenting with autoimmune hyperthyroidism. What are the second evidence supporting hashitoxicosis? Now, this is the commonest type of autoimmune hypothyroidism these kids get, and usually the child is asymptomatic, and maybe the COVID-19 pandemic had led to a longer duration of hashitoxicosis. Now, he is 12 months in the state of hyperthyroidism. So maybe the COVID-19 period had led to this change and dysregulation where he stayed longer in the phase of hashitoxicosis. However, there are evidence against both diagnoses. This is male. An autoimmune disease occurs more in female kids. The antibodies are weak, so we can say that may be negative. And the child is asymptomatic, and the response is quite unusual compared to these two kids with true Graves' disease, and the imaging was normal. So, last visit I saw him last month. He's under close observation off medications. Maybe this is relapse or incompletely treated Graves' disease. Is it longer duration of hashitoxicosis? This is the COVID effect. We don't know, but me and the family agreed that we will be off medications, and he is currently asymptomatic, and we're closely monitoring the thyroid function test, and he's due for a repeat in his thyroid stimulating antibodies. So this is my conclusive message. Hyperthyroidism is quite challenging in kids, and I think the COVID-19 pandemic may have changed the face of presentation and diagnosis of autoimmune thyroid disease in kids. Thank you very much, and these are my acknowledgement lists.